Welcome back. Today with me in studio, I have Dr. Michael Demeure. He's with Precision Medicine at Hoag Hospital, and we're going to talk a little bit about precision medicine, where it's going, and kind of how it's helping everybody. Well, welcome. Thank you for being with us. So, first of all, before we go into precision medicine, tell me a little bit about what you and I were talking about beforehand, about how it sort of came about and it started out at another company.
Well, the human genome was sequenced in around 2001-2, where we have a lot of information now that decodes cells, and the hope was to get that to patients to transform medical care. And there's been government initiatives, private initiatives, and cancer is leading the way. And I've had an active research lab for 20 plus years looking at various cancers. And so I was working at TGen, which is Translational Genomics. It's a nonprofit research institute in Phoenix. Its goal was to take genomics and get it into patients. And they started a biotech spinoff that I was helping with. I was their chief medical officer and helped run it for a while. Hoag Hospital was a customer. And we got talking with the leadership of the cancer center, and next thing you know, I'm here.
Right.
And we're trying to get all that genomic technology to benefit our patients here and develop programs.
Okay, so when you first came to Hoag, what were some of the challenges that you had?
Well, Hoag is pretty far along, and there's a lot of infrastructure. We're fortunate that we're well supported by the community, so there's funds to do these innovative things, and there's an innovative leadership that wants to do and adopt the latest technologies. But there are challenges. The biggest is early adoption of new technologies always depends on people understanding it, buying into it, understanding how it can help their patients. There's always issues around funding with insurance companies who's paying for the testing and things like that, and then when to best use it, how to best use it, and it's an iterative or an ongoing process. Okay,
and so are you educating the doctors on how to utilize it, and then in turn they educate their patients?
Yeah, that's part of what we do. I mean, we've got a pretty great medical staff, but the new technologies are evolving so rapidly, to keep up on it is difficult. So we've instituted molecular tumor boards. So doctors bring their patients' stories, scenarios to the clinic or to these conferences, and we also discuss the genetic tests that are done on patients' tumors and identify particular gene abnormalities we call mutations, and discuss how that information might be used to select a better treatment for the patient. In some cases, there's clear scientific evidence that using that information will benefit the patients. Other times, it's more hypothesis or speculative based on our understanding of molecular pathology.
Right. Okay, and then in terms of, you're using this with cancer disease programs, and let's talk about how you're applying that to certain cancers.
Yeah, so probably the furthest along is a general concept is lung cancer, where we know that there's a panel of certain particular mutations. One might be 4% of all lung cancers, but if you have that, you will do better on a targeted drug that targets that particular mutation than on standard chemotherapy. Other times, it's guiding the use of things called immunotherapy. So we know that if there's a lot of mutations or expression of certain proteins on the surface of cells, that would indicate that these immune drugs may work better for the patient. And other times there's a patient that's, I'll say standard therapies have failed the patient. They've tried the different standard chemotherapies and nothing's working. So then we do sequencing and hope that we find something that may be more effective, or that we can guide the patient onto a clinical trial based on their particular tumor and the genetic analysis of their tumor.
Okay, so I've talked to a variety of different surgeons and oncologists regarding breast cancer, and so I know, as some of the things you were mentioning, there's a variety of different genes and things that go into the research. So when it comes to breast cancer, what are some of the things that you guys are doing with precision medicine?
Breast cancer is, the precision medicine that probably is been standard in a different way. We've always looked at estrogen receptor, progesterone receptor, and things like that. And there's a lot of clinical trials so that we have first-line therapies, second-line therapies, third-line therapies for breast cancer. So we're not usually seeing the genomic testing of tumors until further along in the progress of that disease. So I'd say breast cancer is probably not one where There's a great role as of right now for most patients. I mean, the survival and improved survival in breast cancer has been largely because of earlier diagnosis with screening and also with better chemotherapies. But an area where genomics really has come into is in the genetic screening for hereditary breast cancer syndromes.
Okay.
Angelina Jolie made that very well publicized. So if we can identify patients that are increased risk, we can either adopt a strategy of more early or more frequent screening, prophylactic surgery, mastectomies and reconstruction, or chemo reduction or risk reduction with anti-estrogen drugs, things. All those various things are considerations. But it also then you identify family members. What's not well appreciated that men are also at increased risk with those same genes. If you have the BRCA2, you might be at increased risk for prostate cancer or pancreas cancer. And so we're enrolling male relatives of patients identified with those genes into high-risk screening programs for pancreas cancer, for example.
Right. Well, that's great. I mean, it seems like we've come a long way from where we started with all of this. And so what do you anticipate happening for the future?
Well, I think right now we look at DNA because the technology is more robust. It's easier to analyze DNA from tissue samples that are embedded in wax. The technology of doing RNA sequencing is not quite as far along, but RNA in some ways is more informative than DNA. Because those are the genes that are turned on or off. And having improved technology, and again, continued reduction in cost, will help us. But then we also need better drugs, and we also need better understanding of the ability to match the genomic changes with drugs. Because we know sometimes it's context dependent. A gene-drug match may work for one particular tumor, but in another type of tumor it won't. So we have to understand better, so we can use the information we get better.
Right. Well, we're hoping that you bring all that technology to the doctors, and then in turn they do the same to the patients. So.
That's what we're all about.
All right. Well, thank you so much for the information. I appreciate you being with us.
Thank you for your time.
All right. And if you have any questions regarding this type of program or any program at Hoag regarding cancer or research, you can go to 949-7-CANCER, and that's 949-722-6237. And we'll be right back after this.